Start with Good morning, everyone. Today I'm going to present examination of gastrointestinal system. First, we'll start with the oral cavity. We will be needing a torch, a tongue depressor, a pair of gloves are necessary for the examination. We'll first see the hydration status and the fetor, that is, if there is any bad breath. We will ask the patient to take out their tongue with the help of a tongue depressor. We will depress the tongue and inspect the oral cavity for leukoplakia, erythroplakia, candidiasis, and ulcer. As we can see in the in above pictures, the candida, the leukoplakia in the tongue, and the oral ulcers. Then in teeth and gums, nicotine staining is present in patient who smoke. Gum hypertrophy may be present due to smoking, and these are also some adverse drug reaction of phenytoin, phenobarbital, and scurvy. In lips, as in the diagram, we can see the angular stomatitis, that is cracks at the corner of mouth. It indicates some nutritional deficiencies, which include B6, B9, B12, and iron. Yes. Abdominal region, these are divided into 9 quadrants by 2 horizontal lines and 2 vertical lines. The 2 vertical lines crosses the mid-clavicular line, and the 2 horizontal line, the upper horizontal line passes from subcostal region and the lower horizontal line passes from transtubercular plane. Now about the clinical examination. Clinical examination is to be done under 4 headings: inspection, palpation, percussion, and auscultation. First, we'll start with inspection. While inspecting, first we have to introduce ourselves to the patient. Then we have to take a verbal consent. The patient should be relaxed, ensuring that the bladder is empty. Patient should lie flat as seen in the picture on their back with hand by their side. His hip and the knee should be flexed, and exposure should be from xiphy-sternum to the suprapubic area. Now, inspection. First, we have to see the shape of the abdomen. There may be a generalized fullness or a localized distension. In case of generalized fullness, generalized distension, there are 5 F's that may cause generalized distension. These are fat, fluid, flatus, feces, and fetus. In localized distension, it may be symmetrical or it may be asymmetrical. In symmetrical localized distension, it may be because of some small bowel obstruction, and asymmetrical may be because of gross enlargement of spleen or liver or kidney. Scaphoid abdomen. As we can see in the diagram, it is seen in advanced stages of starvation and malignant diseases. Now we'll look at the umbilicus of the patient. Normally, the umbilicus is slightly retracted and inverted, as we can see in the first picture. And it may be everted in case of umbilical hernia. There may also be present a slit. Slit may be a vertical slit or a horizontal slit. If we are seeing a vertical slit, as in the diagram, it is because of pelvic and a ovarian tumor. And if there is a horizontal slit, it may be because of ascites, that is because of cirrhosis of the liver. Then we can also inspect the movements, the visible pulsation, and the visible gastric paralysis. Movements are gentle rise in abdominal wall in inspiration and fall during expiration. In peritonitis, the abdomen is also called still or silent abdomen because there is no movements. Visible pulsation. Pulsation may be seen either normally in a very thin patient or in abdominal aortic aneurysm patient. Visible gastric peristalsis. It is mainly seen in gastric outlet obstruction from left hypochondrium or epigastrium toward the right lumbar region. Now, we'll also inspect the skin or the surface of abdomen if any change. There may be some purple stria present, or maybe some dilated veins present, or there may be some red color stria present. First, in the diagram, we are seeing stria gravidarum, that is produced by gross stretching of skin. With rupture of elastic fiber, it indicates the change in size of abdomen, as in pregnancy. The purple stria, that is seen in Cushing syndrome. Caput medusae. Due to distension of veins around the umbilicus, it mainly signifies portal hypertension. Then at last, we also have to look for the hernial sites, mainly inguinal hernia, then sphignalian hernia, the umbilical hernia, the epigastric hernia, and the incisional hernia. Now we'll come to the palpation. First, we have to start the palpation from the place where the patient is not having pain. If the patient is not having any pain, then we can start from the left iliac fossa, palpating lightly and working anti-clockwise to end in the suprapubic region. The order of palpation of organs are: first, we'll start from left kidney, then to spleen, then right kidney, then liver, then urinary bladder, then aorta, then palpate both the groins, and at last examine the external genitalia. Steps for palpation. We can palpation can be superficial or deep palpation. While doing superficial palpation, we have to use light pressure. As seen in diagram, use the flat of the palmar surface of the finger to palpate through the abdominal wall. We can see tenderness. Tenderness is pain on pressure. The rebound tenderness, also called as Bloomberg's sign, the pain on releasing the pressure. Then we can also see guarding and rigidity. Guarding is a voluntary tensing of abdominal wall, and rigidity is involuntary tensing of abdominal musculature. Then on deep palpation, it can be done using one or two hands, making sure that we do not push both the fingertips. It is for mass and organs. Then will come for organ palpation, that is the liver palpation. We always have to stand on right side of the patient, starting from the right iliac fossa and move upward. The hand should be stationary during inspiration and move during expiration. Liver moves down during inspiration. It can be felt by radial border of the index finger. Then spleen palpation. For spleen palpation, we also have to stand to right of the patient. Patient should be in the supine position. We'll start from right iliac fossa to the left hypochondriac region. Edge of spleen can be felt during deep inspiration. Then kidney palpation. First, for the right kidney, we'll stand on the right of the patient, place right hand anteriorly in the right lumbar region and left hand posteriorly in the right groin. Push forward and with left hand, lift right hand inward and upward. Lower pole of kidney can be felt between the two hands and can be ballotted. Left kidney is not usually palpable. It is only palpable if it is low in position or if it is enlarged. Now, the third technique is percussion. This technique allows us to evaluate the size of some of the organs and allow us to detect the presence of excess fluid or air. Middle finger of the left hand should be placed on the part to be percussed, and with slight extension of the distal interpharyngeal joint, blow at the back of BIP by sharp, and there should be the wrist movement should be present. We can elicit three things: the tympanic sound, the hyperresonant sound, and the dull sound. If there is dull sound, then it indicates that there is an organ or the fluid present. Hyperresonant sound indicate gas. Resonant sound indicate the presence of gas, and tympanic sound predominate due to gas in the GIT. Percussion can be done in case of fluid present in the peritoneal cavity. We can see the shifting dullness, the fluid thrill, and the puddle sign. Now about the shifting dullness. In normal individual, the flanks are usually resonant. We have to percuss laterally from midline until the dullness is detected, until the dullness is detected. Now turn the patient to the left or the right lateral decupitous position, waiting for 5 minutes. The previous dull area over the flank become resonant. If this shifting dullness is present in a patient, then we can estimate that about 1000 ml of fluid should be present in the patient. Now, fluid thrill. Fluid thrill is felt when more than 2 liter of fluid is present or the ascites is tense. We have to place the palm of the left hand against the left side of the abdomen. We can ask the patient to put the edge of the hand on the midline of the abdomen. Now we can flick the finger against the right side of abdomen. If ripples are felt upon flickering, we can call it a fluid thrill, and it will indicate that the fluid is more than 2 liters. Then puddle sign. Puddle sign is for it can detect as little as 120 ml of fluid. This sign is elicited to detect the presence of normal fluid when flanks are resonant. This can be elicited either by percussion or by ausculto percussion. Can detect as little as 120 ml of fluid. Patient is to lie in the prone position for 5 minutes and then goes on all four limbs so that middle portion of the abdomen is dependent, as seen in the above picture. Now we have to focus around the umbilicus and elicit the dullness. If it is not elicited, we can also ausculto percussion by placing our stethoscope on the belly, around the belly, and scratch through a pen. If we'll feel the dullness, then it is the positive puddle sign. Now about auscultation. Auscultation of the abdomen is done for bowel sounds, succussion, splash, the venous hum, and the bruit. Bowel sounds, motility of gut create gurgling sound, gurgling sound. Even these sound increased in small bowel obstruction, bowel obstruction. 5 to 10 second bowel obstruction, malabsorption, etc. It decreases in paralytic ileus and peritonitis. There is a bowel sounds in every 5 to 10, or in some book there is written 10 to 20 seconds in normal individual. Then a succession splash, the sound resembling shaking of a half filled bottle. It is seen in pyloric stenosis. These are a diagrammatic views where we can see these sounds. First, the bruit. These are variable harsh sound due to turbulence in arterial flow. Auscultate aortic bruit, midline between umbilicus and xiphoid. Renal bruit 2 inches superior to the lateral umbilicus, and common iliac midway between umbilicus and midpoint of the inguinal ligament. Then the venous hum is continuous, softer, and lower pitch than bruit. It signifies portal systemic shunting of venous flow when portal flow is obstructed. It is usually heard over the liver area and the umbilicus. Ma'am, first we'll see any spider nevi. If present, it is seen in liver disease. We can also see the astraxis sign, that is trembling of hand. We can also see gynecomastia. It is also present in chronic liver disease. And ma'am, we'll see ma'am in hands, in finger we'll see the ma'am pitting in the nails is seen. And ma'am, during abdominal palpation, if it is a case of chronic liver disease, or if it is going towards cirrhosis, we can also see some fluid present, that is ascites, and the liver span might be increased. We can see it in percussion. Ma'am, plucking of the hair, ma'am, alopecia is present. Thank you.
Good afternoon, everyone. My topic is respiratory system examination, and my moderator is Dr. Abhishri Ranjan. The systemic examination is done under 4 headings, that is inspection, palpation, percussion, and auscultation. We start by examination of the upper respiratory system, like we examine the nostrils, nasal septum, and nasal polyps. Nasal septum perforation can be seen in cocaine abusers also, and crusting can be seen in cocaine abusers. And likely oral cavity and pharynx can also be examined for pre-malignant conditions like leukoplegia, etc. Now we start by inspection of the lower respiratory tract. Now all the clinical examinations should be compared on both sides of the following area. We have the 8 areas, that is the supraclavicular area, infraclavicular area, mammary, axillary, infraaxillary, suprascapular, interscapular, and infrascapular. Now here, these are the areas where we have suprascapular, infrascapular, then mammary, axillary, infraaxillary, and posteriorly we have suprascapular, interscapular, and infrascapular. Earlier it was clavicle. We start by inspection. We start by inspecting the shape and symmetry. Normally, the chest is circular in infants and symmetrically elliptical in adults. The contour is smooth. The transfers to anteroposterior diameter, the ratio is 7:5, which is known as Hutchinson's index. Now, there are few deformities of the chest, like there's a flat chest, there's pectus carinatum, that is the forward protrusion of the sternum, that is seen in rickets. Then pectus excavatum, that is the funnel chest. Then we have ricketic chest, scorbutic rosary, barrel-shaped chest, flail chest. Then we inspect the position of the trachea. We have the most common trail sign, that is the undue prominence of the clavicular head of sternocleidomastoid on the side to which the trachea is deviated. Like in this image, we can see the right side of the sternocleidomastoid head is very prominent. Then we can see the position of apex beat, that is seen in the mid-clavicular line in fifth intercostal space. Then movement of chest is determined in the terms of rate, rhythm, and type of breathing. The normal rate is 14 to 18 breaths per minute. And there are two types, thoraco-abdominal, which is mostly seen in women, and abdominothoracic, which is seen in men. Now, if the respiratory rate is more than 20 per minute, we call it tachypnea. There are various conditions which cause tachypnea, that is nervousness, exertion, fever, hypoxia, and many respiratory conditions also, like pneumonia, ARDS, metabolic acidosis. The rate less than 14 breaths per minute is known as bradypnea. Conditions are alkalosis, hypothyroidism, and narcotic drug poisoning, raised intracranial tensions. And this term hyperapnea, it is increase in depth of respiration, and the conditions causing hyperapnea is acidosis, brainstem lesion, hysteria. The rhythm, normal respiration has regular rhythm, with inspiration is longer than expiration, and the muscles of the inspiration are mainly the diaphragm and the external intercostal muscles. There are main muscles. These are the main muscles of respiration, and we have accessory muscles of respiration also, like scalene, pectoralis, sternocleidomastoid, trapezius. Likely expiration, which is a passive process, and the accessory muscles are latissimus dorsi and internal intercostal muscles. The abnormalities of rhythm are, there are a few different types of abnormalities, that is Kussmaul's respiration, in which we can see the depth and rate of respiration is increased. It is seen in diabetic ketoacidosis, alcoholic patients, starvation, and pontine lesions. Then we have Biot's breathing, in which we have apnea between different shallow breathing. In this diagram, it is represented. These are that C picture, we can see our apnea and then severe shallow breathing, that is Biot's breathing. And we have Kind-Stokes breathing. It is characterized by rhythmic waxing and waning of respiration with regularly reoccurring periods of apnea. We have waxing, waning of respiration. In B diagram, it is visible, waxing, waning, and then we have period of apnea. Kind-Stokes breathing is seen in physiological causes like voluntary hyperventilation, high altitude, and pathological causes are chronic heart failure, brain damage, uremia. Now, in inspection, the last is we can see for visible pulsations, scars, and sinuses. We can check for collaterals around scapula, engorged vein in the anterior part of the chest. There are various reasons for it, like bronchogenic carcinoma, mediastinal growth, and any pulsatile swelling in anterior chest. Visible scars can be due to of previous surgeries, some pleural fluid aspiration, anything, and sinuses can be abscess draining points, empyema thoracic. The second is palpation, the palpation of trachea. Trachea is normally situated in the midline. We use this test where we place the index finger and the ring finger on the medial head of clavicle and trace the trachea from above to downward from our middle finger. It is normally situated in the midline, and apical impulse is palpated in the mid-clavicular line, fifth intercostal space. So shift of apical impulse and trachea in the absence of chest deformity indicates the mediastinal shift. And if the mediastinal shift is of the to the same side, then it is due to fibrosis or collapse. And if it is due to it is to the opposite side, then it is due to pleural effusion, pneumothorax, any tumor. And if there's no mediastinal shift, it is seen in pneumonia, COPD, asthma, etc. Measurement of chest expansion. It in women it is measured below the breast, and in males it is measured at the level of nipples. So we by an inch tape we'll measure the normal chest circumference, and then we'll ask the patient to deep inspire. Normal expansion is 5 to 8 centimeter, and if it is less than 1 centimeter, it is seen in severe emphysema. And there's one non-respiratory cause also, that is ankylosing spondylitis. Assessing the symmetry, these assess the symmetry of the upper thoracic part, the anterior thoracic part, and the posterior thoracic part. So in the upper thoracic part, we keep both of the hands on the shoulder of the patient and ask the patient to inspire, and then we see the movement of the chest, whether it is equal on both the sides or not. Likewise, we in anterior thoracic expansion, we keep our thumb in the anterior part of the chest and ask the patient to deep inspire, and then we see the movement of our thumb in respect to the midline, whether it is moving equally or not. Likewise, the posterior thoracic movement is seen. Then there's vocal phrenitis. The sounds produced by vocal cords are transmitted along the tracheobronchial tree and heard over the chest wall. Now we'll place the ulnar border of our hands on identical areas on both the sides of the chest and ask the patient to repeat 111 or 999. So we can check for the vocal phrenitis. If vocal phrenitis is increased, then there are conditions like consolidation, large cavity, some fistula, bronchopleural fistula, and decreased in pleural effusion, fibrosis, and collapse. Percussion. Now the finger which is placed on the chest wall is the fleximeter, and the finger from which we percuss is the flexor. So there are few areas like in anterior chest wall, we percuss to clavicle, supraclavicular region, infraclavicular region, and second to sixth intercostal spaces. In lateral chest wall, we have 4 to 7 intercostal spaces, and posterior we have suprascapular, interscapular, and intrascapular. These are the areas. And then we can hear sometimes few types of percussion notes. Tympanic note is heard in hollow viscous. Subtympanic is heard above the level of pleural effusion. Hyperresonant is noted in pneumothorax. Resonant is noted in normal lungs. Impaired is noted in pulmonary fibrosis. Dull and stony dull. Dull is noted in consolidation, while stony dullness is noted in pleural effusion. Now, auscultation, we auscultate in step ladder-like fashion. We'll compare from both the sides. Now, 3 types of breath sounds are heard. That is, one is vesicular, second is bronchial, and third is bronchovesicular. Vesicular breathing is heard in most of the chest. Bronchial breathing is heard in larynx, trachea, and between C7 to T3. And bronchovesicular is anteriorly first and second intercostal spaces, and posteriorly between the scapula. Further, bronchial breathing is divided into tubular, amphoric, and cavities. Vesicular breathing is low-pitched rustling in nature, with inspiration is longer than expiration, and there is no pause in between. Bronchial breathing is loud, high-pitched, expiration is greater or almost equal than inspiration, and there is a pause in between. And we have bronchovesicular, where expiratory phase is longer, loud, and high-pitched than inspiratory phase. Then we have few adventitious sounds, which are continuous and discontinuous. The adventitious sounds can be of high-pitched, that is V's, and low-pitched, that are rhonchi, and discontinuous are repetitions and pleural rub. V's is high-pitched. The frequency is 400 hertz. It's of hissing quality, musical. It is basically musical. And rhonchi are low-pitched and of snoring quality. So this is the audio of a V's. And this is bronchi are somewhat of snoring nature. Then we have pleural rub and crepitations. Pleural rub is both inspiratory and occur in both inspiratory and expiratory processes, whereas crepitation is inspiratory or expiratory both. This is the pleural rub. And crepitations can be coarse crepitations and fine crepitations. This is the audio of a coarse crepitation. Then the last point is vocal resonance. Now we have to make the patient sit and we have to place the stethoscope firmly on the chest wall, and then we have to ask the patient to speak 111 or 99. And if the vocal resonance is increased, then it is due to consolidation or lung cavity or bronchopleural fistula, and decreased in pleural effusion, pneumothorax, fibrosis, etc. Now there was one article on substance disorder use and pulmonary diseases. So it is seen that tobacco causes high risk. Tobacco is a high risk factor for causing COPD and bronchogenic carcinoma. Cannabis causes lung cancer and some allergic bronchopulmonary fungal infections with aspergillus mucus. Opioids inhibits the respiratory drive and hence may lead to death due to respiratory failure. And alcohol increases the susceptibility to lung infections and injuries. And methamphetamine and cocaine causes idiopathic pulmonary arterial hypertension. Then we have a cracked lung syndrome. It is defined as acute pulmonary syndrome consisting of diffuse alveolar damage and hemorrhagic alveolitis occurring within 48 hours of smoking cocaine. Patients present with dyspnea, fever, cough, or hemoptysis, which may progress to respiratory failure. Radiographic findings are non-specific and ground glass opacities may be seen. And management is mainly supportive to maintain adequate oxygenation. Ventilatory support can also be provided. These are the references. I request Dr. Abhijit to kindly